Can I just say that as a generalist coming here speaking to a room full of specialists, it's extremely intimidating. I've learned an awful lot in the time that I have been here today, and I'm sure that I have a lot more to learn. But could I just say then, if you wouldn't mind confining your questions to issues of telecommunications regulation, which I do actually know something about, I think we'll all get on better. I just wanted to say a couple of words in general about competition before I start on the issues of the health service, because I think sometimes there's a perception that when we talk about competition, we're only talking about price. And I think particularly in a very heavily regulated sector, and rightly heavily regulated sector like medicine, it's important to bring out the other dimensions. One of the dimensions that we would talk about a lot is quality. And I do feel that competition has a role to play in ensuring quality. And it's not necessarily competition in the direct sense that we think about it generally, but in relation to how standards are created, how people are incentivized to reach standards, because really you're comparing yourself against the best in class when you're looking at standards and when you're looking at the sort of nudges that can be put in place to move people towards complying with best practice. I also wanted to talk about innovation. And, I think this is absolutely the right place to do it. I think this is an unbelievable centre. It's absolutely fantastic. I had the tour of it at lunchtime. And to see GPs grouping together and creating something like this, a facility of this level, getting the throughput that they're getting the quality of patient care, getting the facilities, it's just amazing. And one of the other professions that we've dealt with a lot in time is barristers. And barristers absolutely insist that it's part of their professional integrity that they have to act as sole traders. And there's this notion that if you're a barrister and you go into chambers or you go into partnership with somebody else, suddenly, your ethical standards collapse. You're only concerned about, the profits of the partnership or the enterprise as a whole. And, I'd love to get some of them down here and, walk them around and show them this is how it actually works in practice. This is how collaboration can work. This is how you can work together to improve care. So, oh no, we're not getting the thing out. We are. Okay, yeah. Talking about the universal health system here, you're at a bit of a loss, we're at a bit of a disadvantage really, because we just know so little about it. So, we can know what has been told to us so far, what was in the programme, which is mainly what was in the programme for government. We know a little bit about, there's been a bit of progress on the risk equalisation issue, but really, as Tig said, we're looking at models elsewhere and trying to see what's happened elsewhere. And what we can learn from that and what we can suggest. So far as we know, there's going to be the introduction of universal primary health care on a phased basis, initially with people on certain Department of Health schemes, and then eventually by 2016 for everybody. Universal health insurance is going to be one tier, as Lona said, compulsory, with a certain basic guaranteed package for all. It'll be free or subsidised for lower income groups, and the government have said that there will be competing public and private insurers. There's certain crucial elements of the framework that have to come out. One of them that we were awaiting was the risk equalisation system. Well, the bill on that has been published, but there are still some details to come. There's the report of the UHI implementation group. Tig mentioned that there weren't GPs represented on it. My understanding is that I've heard complaints from the insurers that they're not represented on it either. And I'm not sure that there's a representative of current healthcare providers. I know there's certainly somebody who was the chief executive of a healthcare provider. So I don't know whether that's been a deliberate decision to have this report done by people who are not currently involved in the system. Again, we don't know whether there's going to be a further phase of consultation or whatever. And then there's a white paper on financing UHI. And Tig said this already, and I had it in my slide already before you said it, right? That the devil will be in the detail, and that's the case. We are kind of talking a little bit in a vacuum at the moment. Some markets, we come from the Competition Authority, we look across all different kind of markets. Some of them, there's no need for regulation. I mean, despite, sometimes there are clamours from particular groups that there should be regulation, or there should be increased regulation for the protection of consumers. I myself have made numerous ill-advised purchases in the shoe department, which are all sitting in the back of my wardrobe because I can't walk in them. But there isn't a job for a regulator to come in and tell me not to do that. Okay, I'm all grown up. It's my business if I make bad decisions. But certainly within a market like medicine, where there's such, what the economists would call such an information asymmetry between the provider and the patient, and where people may not understand the quality of care even after they've got it. They may not know. So you need systems in there. You need stringent standards for the qualification of doctors. You need to keep up those standards. You need the sort of quality initiatives that we've been hearing about earlier on. So, we understand very well that, the overall system will define the space within which competition can occur. You know, it's not going to be a free-for-all. But what we want to see is work towards establishing the systems for effective competition, and that means getting the incentives right. I mean, the things that you really need for competition to work, there's entry, insofar as it should be as easy as possible given the quality standards for people to get into a market. There shouldn't be undue barriers to entry. There's choice within that for patients, so that if they want to switch, they should be able to switch. But the third one, and the most crucial, and it was mentioned several times this morning, is information. And you really need to have information getting out there, information that people can compare, information that the authorities can use on behalf of patients to create the incentives to move people toward the direction that they want. To use a famous quotation, there's three of us in this marriage when it comes to universal healthcare. There's a sort of three-way relationship there, and many aspects of this relationship are just not clear. They're the kind of crucial things that have to be decided in terms of the shape of the new universal health insurance system. There are decisions for the patients. There's the immediate decisions as to their care. Do they seek medical care or not? Where do they go? What insurer to use? The degree of choice that there's going to be among different packages, because one of the issues that people see a lot in the current system is that while notionally there's community rating and risk equalisation, the proliferation of packages that are produced are actually a form of selection among different patients and of risk weighting. So we don't know then the extent to which people will be able to purchase add-on packages over and above the basic. For insurers, there's this question of, which provider do they use? Do all insurers use all providers, or is there selective contracting, which is, a difference between other healthcare systems. In the UK, you've got a system of kind of a single purchaser. In the Netherlands, individual insurers can contract with individual healthcare providers. But there is a big issue here in Ireland because of the current structure of the health insurance market. Then again, the question of which additional services to cover. The hospital's primary care centre, how do you decide on treatment, on admission, the intensity and frequency, and all those decisions that we're not really going to know a lot more about, I think, until we see the funding model fleshed out in a lot more detail. So the situation of competition in primary care today, well, speaking as the Competition Authority, we would feel that some of the existing restrictions which were unnecessary have been removed in terms of the opening up of GMS contracts. Going back some time, the advertising restrictions have been removed, and there's greater recognition of alternative routes towards training and qualification while keeping the same quality standards. And we would feel that, even as it stands, patients are benefiting from increased innovation and more choice and more price transparency. One interesting thing I think that's happened, and that, again, people here would know a lot more about than me, but it seems to me that there's a bit more innovation in pricing as well. Maybe it's due to the recession, I don't know, but people feeling that, doctors offering to treat a family for a certain amount, offering flat fees and so on, moving away from simple fee per call, and maybe all those things have always happened, but there seems to be a little bit more promotion and advertising in relation to them now. So how might it go? How might it look going forward? Well, if you're providing free GP care for all, you're taking away that element of price competition at the point of delivery. Now, as I've said, price is only one factor which makes people choose to go to a GP. It might make them choose whether to go to the GP or not at all, in fact, but also as between choosing between GPs. But we expect that there will be competition on quality, and the patients will be able to observe and respond to differences. Now, some of those differences will be very obvious. I mean, it seems to me that there's a very obvious quality benefit for patients in coming to a place like this, where you've got kind of a one-stop shop, and you can go. You go to the GP, the pharmacy, the physio, every other facility that we have here. But there are other, less tangible elements of quality. I'm just talking about from the point of view of the patient, because the patient isn't really going to understand the types of quality measures that we've heard talked about earlier. But those are, I think, more for the regulatory system to impose. It appears there's going to be compulsory patient registration. Well, if there is that, we would say that it's important for patients to be able to switch easily to another provider, and that goes back to the issue of information technology and smart cards, and can you take your information with you? And the question as to how that Tig raised as to how GP practices will be funded, and the fact that we just don't have a whole lot of information about that at the moment. In terms of competition among hospitals, well, clearly there's going to be competition for funding, and the bits in italics there are extracts from the programme for government. So they're saying that hospitals will be paid according to the care they deliver, and money follows the patient. Well, I think that's kind of, it's quite hard to know whether they mean that's static or dynamic, because you could take the argument that the hospital budgets at present seem to be quite historically based. You know, they're not kind of they're not constructed from the bottom up on the basis of the amount of treatments that the hospital do. But do they mean just that budgets will be allocated to hospitals on the basis of the amount of care that they currently provide, or the hospitals will be encouraged to compete so that patients switch and the money switches after them again? It's not clear. But I think it's very important, to have good information on the appropriate types of incentives for success. So just one issue that, going back, can I go back? The whole thing probably crash now. One issue that I just meant to mention when we were talking about the issue of quality, and I meant to ask Jack, I meant to ask your question about it, because I think in your presentation you were talking about the supposed contribution of competition to efficiency and value for money, and being, I think, a little bit sceptical about it, but then talked a lot about total quality management. And to me, when you're looking at once you actually start measuring the quality and comparing it, that's a form of competition, particularly if you start using incentives, because that's what you would call yardstick competition, and it's used a lot in regulation of big heavy industries like water and so on, where you don't actually have competition for the water pipes, but you're saying to one water authority, well, look, these people over here who have a similar set of circumstances to deal with, and I recognise the complexity of trying to do something like this in medicine, but they're doing it much more efficiently than you. What changes can you make in order to come up to that level of efficiency, and what incentives should be put in place to try to encourage you to move along in that way? So, I think the whole quality debate, there's an element of competition in there, because you're trying to get people to move along to the level of the best in class. And just a final point about the hospitals, and I think this is going to be a very, very difficult issue to deal with. It's the issue of specialisation versus competition, because, again, for certain types of operation, probably high volume, low complexity, you could say, well, why don't we have several hospitals doing them and see how they get on, see who's the best at it, and let the money follow the patient in that respect. But then again, there are other areas where if the clinical outcomes are better, if you have one specialist hospital with a big throughput, well, that has to form part of the equation. You can't just say that you should have competing providers for the sake of it. It has to be based on outcomes. And Fergus Clancy, used the term hitting the sweet spot, and I think that's a very appropriate analogy, that you just kind of try to find exactly the right balance. How health insurers might compete, again, I have a lot more questions than answers here. At the moment, the feeling is that a lot of the insurers compete on the basis of risk profile management rather than actual efficiency or administrative efficiencies, or trying to manage claims inflation and so on. And you'd hope that that's something that will be addressed through the incentives that are set up in the new system. Are people going to compete by offering supplementary insurance top-ups for something up over and above the basic package? This issue about the scope for selective contracting, and that's the idea that certain insurers contract with certain providers, certain other insurers here contract with other providers, and there's a sort of a competition at both levels. Well, the issue here, I think, is, can you actually do that? Because is the VHI actually a must carry insurer for any health provider? And I'm not going to say any more about that, because there's a kind of a legal case going on at the moment, and we probably should wait for that outcome. But it's kind of the elephant in the room. So, conditions for effective competition: you have to have the regulatory regime in place and clear. And I think once it's clear and we can move on, people will react, and people will respond to the incentives. There have to be enough insurers and providers. I mean, clearly you should have enough there to provide competition. The financial incentives have to provide move people in the right direction, and people have to be able to respond to them. And again, just on the demand, I'll just emphasise again, enough information, and maybe it's the case that you can never get too much information in this, but that's the desired outcome anyway from this to this. Thank you very much.